Good afternoon and welcome to this special launch of the ESS Round 11 rotating module on social inequalities and health and their determinants. I'm Rory Fitzgerald, Professor of Practice and Survey Research at City St George's University of London and Director of the European Social Survey. And it's my pleasure to be chairing this Topline Results launch today. We have three speakers joining us today. Dr. Mirza Balaj, sociologist and scientific coordinator of CHAIN. Pilar Valeria Texidó, PhD candidate at the Department of Sociology and Political Science at NTNU, part of the CHAIN team who's been publishing in this area. And Terje Andreas Eikemo, who's led the Centre for Global Health Inequalities in Research, CHAIN, based at the Norwegian University of Science and Technology since its inception in 2017. The authors today will be building on the results of the latest ESS Round 11 data, which is freely available from the ESS Data Archive, and drawing some comparisons with the first time this module was fielded in the past. The authors will be presenting for about 45 to 50 minutes, and then there'll be plenty of time for questions at the end. Please put your questions in the Q&A rather than the chat facility. We will be recording today's seminar, and the results, recording of that and the video of the recording will all be made available on the ESS YouTube channel afterwards, and we will send you a copy of the Topline report. So without further ado, I will pass over to Terje.
Thank you so much, Rory. It is truly a pleasure to present to you the latest results of the European Social Survey Round 11, the health module that we have developed in the latest version of the ESS. Now, before I do that, I would like to take you all about 10 years or so back in time to 2014, and even a few years before that. At that time, there was an emerging need to understand the health of populations and their determinants embedded in the social, economic, and political structure of populations. At the time, it was really no survey data source out there that could really capture what is going on in terms of health and their determinants in a comparative manner. With questions that asks exactly the same questions at the same time, that is why we applied to implement what we've later called the health module of the European Social Survey. Now, in this module, we have identified questions that are of vital importance for our health, and also outcomes that relate to our well-being and physical and mental health conditions. We then published in 2014, or it was actually a couple of years later that we published the first paper that mainly presented this first module. And perhaps in the chat now, as you can see, there is a design of the ESS module that was presented in the European Sociological Review. So if you want to learn more of the backgrounds, the theoretical underpinnings, and the empirical evidence needed at the time, you could have a look here. The information is still highly relevant. So back then, we provided governments with excellent tools to get an overview of their health situation. Now, this module was a huge success. We have provided new understandings of health inequalities and their explanations. But as you may know, this was one point in time, and this is also before the pandemic. And we were lucky enough, and perhaps I should add skilled enough, to update the module with exactly the same questions 10 years later, after the pandemic even, which enables us the opportunity to see what has happened during these years. And just recently, we published another design paper that is now has presented the new module, the new ESS Health module, which has been published very recently in Social Science and Medicine. So these two journals also speak to each other. It relates to sociology, and it also relates to public health and medicine. So I'm really excited to be able to show you today what has happened in these years. And these results will then be presented by our colleagues in Chain, key members of our group, Mirza and Pilar. But before you will hear from the results, I would like to just tell you a few words about Chain, who's behind these two modules. As you can see here on this slide, we are not alone in what we do. We have worked with disciplines in our own university, with other universities across the globe, and we also work across sectors. And I think that is something that makes us special. We really like to combine sectors and discipline in order to promote health equity, not just nationally or in Europe, but even globally. Chain is a center for the global study of health inequalities, but of course it is in Europe that our focus has been strongest, with the data is also the best. Perhaps, unfortunately, as this is something we need across the globe, and with the European Social Survey, we have really provided an example of how we can monitor health inequality internationally. And on the next, before we go to the next slide, we're already here, that's fine. Please do follow us on LinkedIn, where we will present further updates on the results of the European Social Survey and also other research that we are conducting. This is the Chain team. As you can see, it was a picture that was taken a few years ago after a kickoff of a huge grant we got from the Norwegian Research Council. But with this slide, I would like to tell you a little bit about our approach. We start by basically building up infrastructures within social science, within public health, within medicine, that will enable governments and to provide tools to mitigate health inequalities. We are providing tools for researchers who can examine health inequalities that are according to the needs in various countries. We are also very interested in translating our research into policy. And that is something we do continuously. We are really visible on the European and global policy agenda. And we even try to do implementation, research, capacity building in various countries, including in the Global South, to make sure that research is translated into action and to change. So the European Social Survey really falls into this mission. And as you can see here, we have been able to capture a lot of the determinants that we, from the available evidence, know really tap into our health conditions. And I guess you're now really curious about the results, what we have actually been able to measure. And in doing so, we will hear now from Pilar, one of our excellent PhD candidates, who will provide an overview of the categories that we have been able to look into, both in the first module and in the second module. She will provide some overview of the prevalences that we now see for various determinants and outcomes, and also how they relate to each other. Mirza will then come in later in the presentation and talk more about that. So I'm really excited that you're all here to hear from us, and I'll also look forward to the questions that you might have after our presentation. So Pilar, please go ahead.
Yeah, thank you very much, Terje. And yes, you mentioned I'm going to be presenting some of the results and some of the differences that we see between the first module that was fielded more than 10 years ago and the one that we got just now, like very recently. And what I'm gonna do, you can see on the next slide, it will be a bit of a lot because you can see a lot of numbers and colors, but I'm just gonna walk you through them and basically just highlight the important things and some differences that are very interesting. As Terje mentioned, we're gonna start by just looking at the ESS7 to have an idea of what the baseline was and really how important and how prevalent were the variables that we incorporated in this module, and then we will compare them with the latest data of ESS11. What we also to basically explain the variety of variables that were included. Of course, you can see in the papers that Terje mentioned before all the details, but in general, what we saw is that we were incorporating questions about social determinants of health and also about health outcomes. So this is a bit the way in which I will present. Yeah, that's basically it. So let's dive right in. Again, don't get stressed by the amount of numbers. We're just going to highlight some interesting ones here. And we can start, for example, when looking at the determinants of health. Maybe one of the first ones that comes up to mind is the healthcare access. And we see that in ESS7, we saw a lot of variation between countries. And this is a kind of variable where, for example, it's more interesting to go country by country and make these comparisons because truly there's a lot of variation. For example, the countries that were reporting more or most unmet need within the healthcare access were reporting 20% of unmet need, and the countries that were reporting less were reporting 5% or 4%. So really the variation was quite important. Then moving into behavioral determinants, what we could see, or something that pops very easily into view, is that there was a gender gap, and that, for example, in smoking, in alcohol consumption, and also in diet, men were reporting much higher levels than women. A bit more into detail, we see that smoking, for example, was lower in Northern Europe, and daily fruit and vegetable consumption was higher among women than men, particularly in Northern Europe as well. In other behaviors, for example, physical activity, we see that there is no regional pattern. And yes, so still up in the first table, if we have time for it, we will look now at no, sorry. Yeah, my Mirza, I think, knows this better than I, so she was right in going into the next slide. Yeah, thank you. Here we can see that ergonomic and material hazards, for example, again, are more prevalent in men, and this group is significantly more at risk. And then, not in gender, but looking more at regional distribution, we see that this is quite interesting as well, because, for example, in Southern and also Central and Eastern Europe, we see that on one hand, household conflict while growing up appears to be less reported than in other areas, while financial hardship was more reported than in other areas. So this is also these lumps of information that can give us a lot of insight. For example, if you compare with policies or even with culture. Yes, and now that we have seen the baseline, we're going to compare a bit with the latest data, which is the exciting part as well. When looking at healthcare access, we see that unmet medical needs have generally increased, and they seem to be particularly driven by long waiting times. And also visits to general practitioner have decreased. So again, we see that there's this increase in barriers maybe of healthcare access. Then moving into risk behavior, we find that smoking rates and alcohol consumption, in general at least, have decreased. So this is good news. But then on the other hand, daily fruit and vegetable consumption has decreased overall. So this is, of course, bad news. On the other hand, again, looking at physical activities, just like with ESS7, we see that there is no clear pattern. Although we can see a bit of a general increase amongst the respondents in Central and Eastern Europe. Yes, now moving into the second part of social determinants of health, we can see that there is a reduction in the exposure to ergonomic and material hazards at work, which, if we remember, these were more prevalent in men. And then there is a marginal increase on household conflict across Europe. And on the other hand, there's a decrease in financial hardship during childhood. So we can also see a bit like maybe historical changes, right? Like if we see it at childhood conditions. Finally, something interesting as well is that the housing conditions have deteriorated across most of Europe. So this, we can say that it's a rising problem. And finally, looking at unpaid care, we see that now there is more people who provide unpaid care. But interestingly enough, the number of people providing more than 10 hours a week of unpaid care has decreased. So this could suggest that maybe even though there's more people working without being paid in care, the burden is more equally distributed. So this is also interesting. And now we will pass into the next slide, thank you, in which we are presenting new variables that we have included only on this ESS 11 round that were not available in ESS 7. Basically, looking at housing conditions, which, as we have seen by the other data, is an increasing problem, and also a sense of control over one's life. We see, looking again generally, we see that in housing conditions, mold or rot, damp walls or leaking roofs, and experience of extremely hot and cold indoor temperatures, as well as noise, are some of the most common housing problems in Europe. So these are also worth going into depth, maybe if you want to do more research on them. And finally, looking at control over one's life, we see that on average, the highest levels are in Northern Europe. So this is also interesting. Of course, there's much more in depth that we could look at, but just to give a preview, this is interesting enough. And now we will move into the second part, which is the health outcomes. We will follow the same pattern. So now looking at the ESS 7 results. Yes, one detail that before I forgot to mention is that to calculate the prevalences, maybe Mirza will mention it as well later, but to calculate these prevalences, we used the whole sample, and then we basically age standardized with the European population of 2013, the European standard population. Yes, so now that we know a bit more about the methods, let's go again into the results. What we see is that for the chronic non-communicable diseases, in nearly all countries and among both men and women, more than half the sample reports having either one or more conditions in the last year. So we see that morbidity and morbidity is really high in Europe. Again, just a quick overview about depressive symptoms. We see that more women report serious depressive symptoms than men, except, interestingly, in ESS 7, Norway and Finland. And then regarding overweight, we see that overweight and obesity is more reported in men than in women. Now, looking into the change of these health outcomes for the latest data, we see that regarding the chronic non-communicable diseases, there's a general trend that basically continues in having quite high prevalences of both. Well, morbidity has gone slightly down, but it seems that maybe it's because it has been transferred to multimorbidity. So people reporting two or more conditions have increased notably and almost universally across Europe. Then looking at depression symptoms and also at being overweight, it continues to have the same distribution, more or less. So we see no clear reversal of the pattern. So more or less, we continue with depression being more prevalent in women and overweight being more prevalent in men. And then a bit more going in depth within the regions and also with this newest data. What we see is that men in Northern Europe exhibit the largest increase in cardiovascular conditions. And in the North in general, we also see an increase in allergies, stomach pain, and skin conditions. And all of this seems to be a big reflected into a big increase also in multimorbidity, and this being hampered, having your daily life being hampered by illness. In Western European countries, we see that generally there was a stability and a slight maybe decline generally in non-communicable diseases, and particularly in women, high blood pressure declined consistently, and also some pain-related conditions, although it will be less consistent. In Eastern and Central European countries, we see that non-communicable diseases decreased mostly. And in Southern Europe, we see a very mixed landscape. For example, Portuguese women seem to have had important health gains, while in Spain, we see a general negative trend, so increase of all these conditions. Overall, we see that there are divergent trends across Europe and European regions, and some countries experience overall improvements. Others seem to stay more or less the same compared to ESS7, and others have a clear worsening trend, let's say. Then, interestingly as well, looking at gender disparities, we see that they were evident. So there were some gender disparities in the trends. And specifically, we see that men seem to increase or seem to report increased non-communicable diseases, and women generally seem to have had an improvement in health. So these are the highlights that we wanted to mention about the health outcomes. I think we can now go into the next slide, which will be presented as well as the rest of the presentation by Mirza. Thank you.
Thanks. Thanks, Pilar, and thanks to everyone for joining. So after an overview of how the health and social determinants in general have changed in the past decade, we wanted to dive in more specifically on self-reported health. Self-reported health is a simple yet very powerful measure that has been fielded since 2002 from your survey, so it's part of the core module. But it's a measure who has been shown to have quite a high predictive value of premature mortality, of participation in the labor market, or disability. So it's basically a barometer to understand how the health of European societies is currently. Here we see data from the European Social Survey 11, and we have ranked countries from those who have the lowest percentage of less than good health reported to the highest percentage. And you can see that there's quite some variability, or otherwise we would refer to this between country inequalities. Starting from Greece, for instance, and Switzerland, that have less than 15% of the overall population that report levels of either very poor or fair health, versus countries at the bottom of this chart, where you can see Lithuania, for instance, Serbia, Portugal, or Germany, where between 40 to 45% of the total population actually falls within reporting of either very poor, or fair health. Countries are sort of divided in half when you consider the 30% threshold. So from Belgium upwards, we have countries which actually a third of the population it's reporting poor health, whereas the rest we see that these suboptimal levels of health are more prevalent and worrying. But how is the health of Europeans distributed about by educational level? So we have respondents who have between 24 to 75 years of age. This is being done for two reasons. First, because we need to have in the sample individuals who have had the chronological time to complete their formal education. And then also we cut off the oldest respondents in order to reduce the selection biases that can be imputed in our data when calculating the inequalities, because people with a higher socioeconomic background tend to live longer. So here we have plotted the predicted probability of less than good health. Again, less than good health is people who either report very poor, or fair levels of health. And we have disaggregated them by level of education. Countries are sorted from those where the lower educated have the highest probability of poor health to those that have the lowest probability of poor health. So as you can see, that variability in overall health is also very much visible in the variability of poor health or suboptimal health, particularly of lower educated. When you look at the dispersion among the higher educated, which in our case, they are defined as people with more than high school, you see that the variation is much smaller compared to the variation between the lower educated, and definitely they are living in a sort of parallel worlds in a sense in terms of health. For instance, higher educated in Europe, they have from 12% probability of reporting poor health up to 37%, whereas lower educated start off already from 25% probability of reporting poor health up to 55% in Lithuania. Nevertheless, it is not a guarantee being higher educated in Europe and meaning that you have better health than lower educated anywhere in Europe. Comparatively speaking, I want to draw your attention again to countries on your left side, on the left side of the graph, like, for instance, again, Serbia, Lithuania, but also Spain or Croatia, where the higher educated, so people with more than high school in those countries, have comparable or even worse level of health than what lower educated have in the farther and in the right side of your graph, like in Italy, Austria, or Sweden and Netherlands. What does this mean? Is that, first of all, education matters, because in every country we see inequalities in the level of suboptimal health by educational level, but also the context matters. In which country you have gained your education, and you live, it also matters for the health levels that you experience. But we often report about relative inequalities in health, and looking at those measures, we intentionally kept the prevalence of poor health or suboptimal health among people with high school or less, and that's how we also sorted the countries, because we wanted to make sure that we send a clear message across, is that just looking at the relative inequalities, which unfortunately is very often done both in academic circles but also in policy discussions, it's at least uninformative, and to some degree it can be also misleading. What that means, if you look at the green squares or rounds, level, you see that actually beside Cyprus, which is a clear outlier, the countries do fall within a certain range which is comparable, which means that you find them across the 1.5 level of relative inequalities, meaning that countries in each country, lower or higher educated, are between 30% to 50% more likely of reporting suboptimal health. Within this range, we do find that some countries actually do a worse job of distributing health among educational groups, and that is the case, for instance, of Germany. If you look at the countries where Germany it's ranked closer in terms of the poor health of lower educated, they are the only ones that are approaching the level of, or twice more likely of reporting poor health among the lower educated. Similarly, among the group is also Norway, and particularly Austria, where they are also twice more likely than the lower educated, the group of countries that have comparable levels of health. What does this mean? Is that when we comment on relative inequalities, we need to make sure that we are comparing apples with apples and oranges with oranges, meaning that we have a situation in some countries where we have a large share of poor health in the country, and especially a large share of that going among the lower educated. those are the countries that we should make sure to firstly compare together, meaning among that level of health, how fairly, at least, the burden of poor health is distributed, and highlight those that are doing best and worse in each of those categories. For instance, looking among those who have lower poor health among lower educated, we can say Ireland is actually doing the best, because we don't even see significant inequalities between educational groups, and you can see this also the green square. It's below, it's quite close to zero. And similarly, Sweden has lower inequalities, but then when you see Greece and Switzerland and Austria, they could basically do better within the overall levels of health that they have. They could do a better job in distribution. We took one step further to understand actually what are the drivers of these inequalities by education in level of health. We clustered our determinants, the ones that we collected data on through the European Social Survey, both in wave 7 and 11, in 3 large groups, which are behavioral ones, including BMI, physical activity, fruit and vegetable consumption, smoking, and alcohol consumption patterns. Under the occupational cluster, we included material hazards, ergonomic hazards, job control, and labor force status. And we brought together, under the living conditions, both material and psychosocial determinants. So we have, for material determinants, financial difficulties, for instance, growing up, or financial strain currently, and quality of housing where they live, but also psychosocial determinants like experiencing of conflicts when they grow up, social networks, how intense the social networks are, if they have close confidence, if they meet often, and sense of control, how much people feel that they are in control of their life. We run logistic regression by country and determine the contribution that each single factor under each cluster has in explaining relative inequalities by education, and then included in the final model for each country only those explanations that at least reduce by 5% the level of inequalities. You can see here in this graph how countries, what are the main explanations by each country, and we have grouped them again in 3 clusters by highlighting in which countries are more dominant the behavioral explanation. The ones in the middle are countries where occupational explanations are more important in that context, and in the third group of countries, it's actually the living conditions. So in all of the countries, except the one that have still an asterisk at the end, after controlling for at least one of these models, inequalities become insignificant between educational levels, but this is not the case for Finland, Germany, France, and Lithuania. We have, in the first group, there are actually 8 countries where the prevailing explanation comes from differences that people or respondents from different educational groups have in terms of behavioral factors, which means particularly BMI, physical activity, and smoking. So it means that in the last 10 years, our educational groups have been making very different choices when it comes to behavioral factor, to the extent that this has become the leading explanation in most countries compared to 10 years ago. 10 years ago, actually, occupational factors were more prevalent in the largest number of countries in Europe, whereas now we have a shift, particularly in countries like Finland and Germany. There is a stronger emphasis on the differences among educational groups when it comes to behavioral factors. Like at a single level, smoking as a single factor, smoking or BMI or physical activity explains between 15 to 30% of the differences observed among educational groups. In the second group of countries, it's occupational factors that are prevailing explanations, and among them, particularly material and ergonomic hazards. So we heard from Pilar that we have seen a substantial decrease to the exposure of material and ergonomic hazards, but it seems to be the case that decrease might have benefited particularly higher educational groups, and thus increase the polarization between them when it comes to this exposure. Again, it is not in any of the context, it is not a single cluster of explanation that is the only relevant explanation. As you can see from the graphs, they are all present simultaneously. In the third group of countries, which is also the smallest one, where 6 countries are represented, it's actually living condition. It's actually feeling of income, which is the most the strongest explanation in all the countries except for Lithuania, where the leading explanation is actually financial difficulties while growing up. But these are individual effects that we see, individual contribution that we see, and each of them can mark, since they are included in logistic regression separately, each of them actually can carry over a bit of the interaction effect when people are exposed to risk factors that come from different clusters, so from occupation and behavior or occupation and living. So we want to dig a little bit further and to see to what extent we have a direct effect that we can account for each of these clusters, and how large is the interdependent effect, which means that requires also interventions that are multifaceted, that try to address simultaneously social determinants that come from different clusters. And this is the picture we get. Again, a very interesting and different picture from what we had 10 years ago. So the first difference is that actually 10 years ago, the interdependent effect, so, or what we call here the combined effect, the blue bar, was the highest among almost all countries in all these 3 groups. This seems not to be the case anymore, which means that more likely in our explanation is that certain exposures are not happening necessarily at the same time equally as it did before. And this is particularly the case for behavioral factors. As you can see in almost all countries where behavioral factors are the leading explanation of social inequalities in poor health or suboptimal health, actually it's the direct effect accounted by this behavioral factors that is even higher than what is the interdependent effect. So what is the interdependent effect? Just to give you an example, is somebody, for instance, or on average people who smoke but also are exposed to certain material or ergonomic hazards, and so they are under the effect of this combination of these 2 exposures, which might increase their risk of having poorer health. It seems the case that actually we have less of these combinations in our data, and primarily the focus is on the difference that has remained among educational groups in certain countries to the largest extent compared to other explanations of direct effect of behavioral factors. This is not necessarily the case when we look at occupational factors, the group of countries in the middle from Italy to Serbia, where actually occupational factors are the leading explanation of poor health. We see that there is a bit of on par, like in some countries, for instance, like in Italy or Sweden or Slovakia, but also Serbia, is the interdependent effect. So exposure to multiple types of determinants of health that actually poses more risk to health of people. And similarly, it's the same pattern emerges also in the last 6 countries, from Hungary to Lithuania, with exception of Lithuania. The interdependent effect, it so means the multiple exposure among different kind of social determinants that is actually the largest explanation of social or educational inequalities and health, which calls for attention more to as I said, interventions that might need to take into account these different facets. So our key takeaways from the data and the changes that we have seen in health and educational inequalities in health in the last 10 years is that Although there are substantial between country inequalities in health, and they have continued, we saw the countries run from 15% reporting less than optimal health to over 45%. Nevertheless, compared to the data we have from 2014 and focusing only on the countries that are present on both waves, we seem to have an upward convergence by countries that were having the highest level of poor self-reported health 10 years ago. Might be the case that these were more easy to gain, like more easy gains to be made among these countries. But we do see in our comparative data that there are the countries that have had the lowest burden of poor health, there are some deterioration, so downward also movement among them, with the exception of Austria and Switzerland. As I said, education matters still everywhere for health in Europe. So everywhere in Europe, if you have higher education, in this case, we're obliged to compare only between people with high school and less versus people with more than high school in order to retain enough data for our part of the analysis on the explanations. But we would expect that these inequalities to be even more pronounced when we disaggregate. And actually, we have done that test, and we know they are more pronounced in those countries where we could disaggregate by 3 levels of education and compare truly the tertiary educated, for instance, versus the lower educated and the middle educated. Again, as I mentioned, context matters. So the country where you live matters, as higher education in some countries experience even worse health than lower educated in others. And one of the, I would say, like, surprises of this analysis was that behavioral explanation had actually emerged as the leading driver of educational inequalities. We believe, but definitely more analysis is necessary, that this comes from higher levels of smoking cessation and lower levels of and frequency of alcohol consumption, particularly among the higher educated in our sample compared to 10 years ago. And so those reduction in exposure to smoking and alcohol might have accrued mainly to these groups, but just as well the increases that we have seen in physical activity. So these are the main messages we prepared for the report, for the Topline report. The European Social Survey itself, but in our case as well, the health module, it's such a rich data set that we are simultaneously working on also on a larger report where we can go more in depth, where more space to go in depth on both trends. And I just mentioned how changes in trends only in overall health, but we do that disaggregated by different socioeconomic groups, both for overall health, for mental health, but also multimorbidity. So there is much more to come, and I invite everyone invited following here to look at the data from the countries that they are interested in, to reach out to us, because we can support you and to take advantage to the fullest possible of this data, because it might take a while until the new module is filed, and this is actually very beneficial also for the policy discussions of where we need to focus more, but also for the research perspective, where we need to know what the effects of our policies in the last 10 years have been felt more and how we can do better for the years to come. Thank you very much.
Thank you very much, Mirza, Pilar, Terje, for a wonderful presentation. Perhaps if we could stop sharing the slides, if that's okay, Mirza, and perhaps if the 3 speakers could turn their cameras on, and we'll move and see if there are some questions. There are some questions. The first is, how do expectations about perceptions of health differ cross-nationally?
So, if I understand, sorry, I'll just. I think so. Basically, health systems and expectations to health vary. So, one way of looking at this would be to compare the countries with different key differences in their health systems. For example, like the Nordic welfare models or health system, for example, with the Nordic countries cluster, I don't think they cluster so much. So from this perspective, perhaps it is not. But I would also like to highlight the importance of cultural variations in the self-reporting, and this is where Mirza actually wrote her thesis on the topic. So perhaps Mirza, if you would like to say something about the meaning of culture and in the reporting.
Thanks, and thank you very much for the question. It is such an easy question, but with a very complex answer. But it's a great question to contextualize a bit health and health perception and health expectations. So when we talk about expectation, usually it's with the average imaginary person in the society. So the average imaginary person in the society in our data changes as that changes from the respondents. So in some countries, it is better than it was 10 years ago. In some countries, it's slightly worse. But generally, when they compare with that average imaginary person, we do find that between educational groups, the changes are not that significant. So that imaginary person is sort of a fixed point for all educational groups. But what matters is actually how people experience health in their setting. So, and that experience can change substantially between people within one country based on their conditions that they live. And the conditions change based on the socioeconomic background in most of the cases. What that means is, like, just to give you a simple example, like somebody suffering from spurs of migraine. So migraine can be quite debilitating, and then it really depends, for instance, on the kind of job you are, kind of support you get in the family, kind of access you are able to get in the healthcare system, and knowledge to navigate the healthcare system that can make a difference of how you experience migraine on the condition. So someone who has to show up at work, no matter migraine or not, or someone who can just easily, without repercussion, cancel a planned meeting because they have migraine, they really experience their physical health very differently, and then they report on those same experience, same condition very differently based on how accommodating is their circumstances of the conditions that they experience a non-communicable disease. And those experiences are actually quite different for the social groups. And that's why we see that even when people have the same health condition or the same number of multimorbidity, they actually report different levels of self-perceived health by education, exactly because that health is experienced in more advantageous or more disadvantageous circumstances of daily life. I hope that answers your question.
Thank you, Mirza. Next question is a more precise one. Why is Ireland missing from the cluster analysis?
Because they have no significant inequalities to begin with. So the educational groups are quite similar when it comes to reporting poor health. We did run the analysis anyway, although just to see for patterns, despite inequalities not being significant. And actually, Ireland, the leading explanation is behavioral factors. Like, if you want to talk about a trend, where do we see more polarization in the Irish society? But we didn't include it in the analysis since there were no significant inequalities by education to begin with.
Thank you. Next question is education really a proxy for socioeconomic status? In other words, from a policy perspective, isn't it more about reducing economic inequality rather than changes in education?
So how will we actually understand this in our writings, in our discussions in Chain? It's actually, education is a proxy of what kind of social conditions you are exposed to. it's not, our discussion is never about we need to push people into higher education, but what we need to do is like to be able to give people a decent wage to live on, to give people the right access or the right instruments so that they can get on in a timely manner to the healthcare system to get the support they need. So what we need to change is not the education of people, but actually the opportunities that people have from from lower economic groups or lower educational groups.
Thank you. Next question. First of all, they say thanks for a great and super interesting talk, which is nice feedback. Please could you comment on the main determinants of poor mental health in women versus those for men, please?
So this is still in the making, the other report, but what we find is actually income. Income is the leading in most countries in Europe, not in most, but in all countries, but one in Europe, which is, I think, Sweden, if I'm not mistaken. A feeling of income is the strongest determinant for poor mental health. And then we have a sense of control and job control to be quite important determinant. But again, depending on the country, I could also show you a mapping that we have, but it is still unpublished, not like the top line, but you have it available. So it's still a bit confidential data.
Thank you. Next question, we might need to ask the author of the question to provide some clarification. Actually, they say, when it comes to noticing health patterns, what system do you use to record data and track trends? I think maybe we need a bit more information about that one.
You're asking a computer program. I didn't get the big start. What software packages? I don't know.
It just says, when it comes to noticing health patterns, what systems do you use to record data and track trends? Maybe the person that wrote that can provide a bit more information on what they mean. Yeah. In the meantime, let's go on. Really interesting question here. I'm interested in the gender differences. What do you think are the drivers of gender differences in health outcomes? And of course, one of the biggest health inequalities really in your data is between men and women, with men at the poorer end of that. So what's going on here? And men seem to be getting worse for men, really. Can you say a bit more about this?
Pilar, let me know if you want to take this, since it's about prevalency.
Yeah, maybe I can make the most obvious thing that seems to be driving inequalities is, I mean, of course, you have to make other kinds of analysis, but health behaviors seem to be risky health behaviors seem to be more prevalent in men than in women. So this is one thing. And also, it's not so much reflected in the data, but looking for, well, yeah, it is reflected if you look at the GP visits for men and women. Also, it's higher for women. So women, maybe this reflects a bit the fact that women tend to look for care, for healthcare faster than men. So yeah, these are some obvious ones. But for example, for depression, we see that depression is more prevalent in women and not in men, and maybe there are other psychosocial determinants that are more important for women. But Mirza, maybe you want to add more nuance.
Yeah, one thing that we see quite gendered is actually the provision of unpaid care. So of course, not every woman is providing unpaid care, but that definitely can be one of the explanations, because they have higher levels of unpaid care to begin with, and then that has been increasing at a faster rate among them, although it seems to be slightly less intense levels of unpaid care, meaning less than 10 hours per week. That number has decreased in a sense. But we do not see by gender we see regional differences for sense of control, like how much people feel they are in control of their life, but we do not see significant gender differences within the countries. And then, as Pilar said, definitely women are eating healthier, smoking less, and drinking less, but and accessing healthcare sooner. But that doesn't mean that women have better health necessarily. For instance, as we said, for mental health, so there are different burdens, but it's also the multiple exposure of the burden. So it's not just the average. On average, women what they are exposed to, but on how many of those exposures they are living with. That's what makes a difference when it comes to reporting levels of health.
Thank you. Next question. To what extent do the social determinants explain increases in mental health cases experienced by some countries? Did you consider other determinants of health inequality, such as age, culture, ethnicity, and policy frameworks?
So in our analysis that we are doing, which we didn't present here because we didn't present mental health here, we actually control for age, but we can see in some countries very different patterns. For instance, in some southern and eastern countries, the older you get, the higher levels of poor mental health you have, which is the opposite in all Northern European countries and some Western European countries. Which to our interpretation is that there is a life course accumulation of disadvantages among Southern and some Eastern European countries that actually, as they age, they have worse health. Whereas it seems that in the Northern European countries, as they age, they accumulate slowly maybe some advantages that may put them at lower risk or at no significant different risk for poor mental health compared to the younger. So very different aging patterns when it comes to mental health in Europe. We do not include culture. We do not have an item about culture. And I have to say we have not done yet analysis by migrant status. We don't have ethnicity in European Social Survey, but we can differentiate between first and second generation migrants. And talking about policy framework, since most of these countries are actually European Union countries, and the policy discourse in Europe has dramatically shifted away from issues of migration and integration of migrants, and it's more of a blaming and shaming and pushing around of the migrants. There's no policy interest in looking at this kind of analysis, but they're really calling to national researchers to actually look at their country context and how people with different migration backgrounds are doing, because we need to put the focus there as well. Despite the European Union policy, it's not really having that as a priority at all.
Thank you. And one last question. When it comes to, just going back to the previous question, when it comes back to data modeling in tracking health trends, what systems do you use to compile the data to begin with?
Rory, I think maybe this question is for you, a little bit about the data access and the batteries we have, right? How to download and access the data and how they can be downloaded into which data packages.
So the data was collected in 2 rounds of the European Social Survey, and in each of the participating countries there's a representative sample of respondents who've answered following a probability-based sampling approach, and they do an hour-long ESS questionnaire that included these questions on health inequalities and then all of the background variables. So it's 2 different rounds of the European Social Surveys, how the data was collected. It's all available from our website, www.europeansocialsurvey.org, and then select data, and you can download all of the data there.
Perhaps, Rory, if I may add, first of all, I think we should add a link to the download page. And for those who have not used ESS before, I would like to say that this is an excellent tool, not just for researchers, for policymakers, but also for students. So if you are, for example, teaching a class in statistics, this is an excellent source of information because the students can download the data in minutes, if not seconds, and it's user friendly, it's recent, it's able to track trends. And what we've done here today is just to scratch the surface of what is possible within one area of research. You can just imagine what you can do once you get to dive into specific areas, be it health inequalities or politics, voting behaviors, and it's really possible to combine like the social structure with the economics, with policy, with health. It's enormous and rich resource, and I think perhaps Rory will not say this out loud, but it's the survey of the highest quality that I think we've used, and it's really has been a long and fantastic process to develop data, and it takes years, and now it's here, and it's the core module is repeated every 2 years. While rotating modules that come every once in a while. So 2 times this has happened with health inequalities. It's now, and it was back in round 7. It is really a valuable resource for anyone who wants to track trends in various determinants and outcomes in question for teaching or policy research, whatever. And this is it's fantastic that we have ESS perhaps I hope you're able to answer this question, Rory.
Thank you, Terje. And also I'd like to thank you and all of your team members for all the work you did in developing the module, of course, writing these top lines and the reports that will follow. And also to thank everyone who was involved with designing and collecting the rounds of the ESS, so the core scientific team, the national coordinators, and of course, most importantly, the respondents all over Europe in these various countries who gave an hour of their time to answer the ESS. If it wasn't for them, we wouldn't have any good data. So excellent. Well, thank you very much to all the authors today and the presenters. Thank you very much to everyone who's attended. Watch this space. There's lots more to come on this module. This is just a first taster. Do have a look at the design articles because that gives you a really good idea of what's in there. Explore the data and keep an eye out by following the Chain LinkedIn page where you'll see all the reports and things posted there. So thank you very much, everyone, and have a lovely afternoon. Goodbye.